Hi, I'm Dr. Kirsten Baca, and I am pressing the, there's my cover. So yes, the topic I've been given today is to discuss what is new in my specialty. I'm an anesthesiologist, board certified and interventional pain management specialist. I practice in my own clinic. I do 100% pain management these days, and I will be speaking on this topic. I have no financial relationships, interest to disclose. I will note that some of the things I talk about during this presentation will be off-label indication or non-indicated or off-label uses for medications. That'll come up as we go throughout the talk. After this lecture, there are a couple of things that I want to make sure everybody remembers when they go home. One, I'm going to talk about the opioid epidemic. It was all we could ever talk about before COVID. So I want to bring us back to that because some interesting data was just released. I will also go into the current CDC guidelines for prescribing opioids. Everyone's likely familiar with the 2016 version that was released in that year. There is a new version that is expected in final form by the end of this year. Next, I'm going to delve into buprenorphine as a primary first-line analgesic agent. Every time I say buprenorphine around other doctors, it's like a four-letter word and all the air gets sucked out of the room. But we're going to talk about this medication and how it can potentially be useful for your patients with chronic pain. Then I'll talk about ketamine, again for chronic pain, another medication that has been around for a long time like buprenorphine, but has seen a new heyday, if you will. I'll briefly talk about some of the emerging non-opioid therapies for pain. My specialty is, or my focus is in interventions. So I'll go over these, but I wanted to focus on medication management today since this is an audience where medications are managed. And then very briefly, I'll talk about long COVID and its contribution to chronic pain, although I noticed there's a talk on long COVID after mine, so we will only very briefly talk about that. The opioid epidemic, again, it's all we could talk about until COVID-19 really drew our attention away from it, but it has not changed, and in fact continues to be a severe, deadly issue. Americans have a fraught relationship with opioids, and we've cycled through periods of overabundance of opioids in the world, in the community, to periods of under-treatment or under-availability. So this current epidemic stems from the 90s or so when the Purdue Pharma drug OxyContin made it to the market and was dramatically or excessively marketed for chronic pain with the inappropriate understanding that patients with chronic pain cannot become addicted to opioids. This is a far too simple of an approach to opioid management in pain. And as a consequence, many of us in this room know that we had a lot of problems with the overprescribing. So the graph on the left is a graph that goes back to 1993, a little bit further, got cut off, and is up to 2020. And what that graph is talking about is the milligram morphine equivalent or approximate dose per person in the United States between this period of the 90s to 2020. And as you can see, as time goes on, there's a steady increase early on, and then somewhere around 1999, 98 or so, we see a much faster increase. The graph on the right represents mortality data. The upper line is male, the lower line is female, the middle line is those two merged. And we see on the left side of that graph, that one doesn't start until 1999, but we see a steady increase in mortality there as well. The key take-homes here is that between 1999 and 2011, opioid prescriptions quadrupled, and so too did opioid-related deaths. So the first thing you might take home from this is that more opioid prescriptions equals more death, so let's stop opioid prescriptions and we'll get less death. pretty obvious, and that's what we started doing. We started pulling back on our opioid prescribing tendencies in 2011. We see a drop, a little bit sharper of a decline in 2016, and in fact, we were able to cut in half our prescribing. However, referencing the graph on the right with mortality data, that is not what is happening. Excuse me, mortality is not following that trend. In fact, it seems to be getting worse. There are a lot of reasons to explain this. I'm going to focus on one. First, I want to point out that the overdose data from the most recent year collected, 2021, was just released last week. It is modified a little bit periodically as updated data comes in, but this is the current final number for 2021. There were 107,622 overdose deaths from drugs, and from that, over 80,000 of them related to opioids. Now, the important thing to look at here is that in the section under opioids, I've separated synthetic non-methadone, or fentanyl, from prescription opioids. And as you can see, the synthetic non-methadone opioids are a vast majority of, or a very important and meaningful majority of that total opioid overdose rate, about 3/4. And if you look at the table on the right, you can see compared to 2022, in all cases except for prescription opioids, the increase in deaths was significant between 2020 and 2021. So this graph goes up to 2020, but it demonstrates the same point. This is a graph of overdose deaths separated out by various different drugs. It also starts in 1999, but we can see that there, in the background, that orange line, that's the top line on the left, that has shown a steady increase as the opioid epidemic proceeded and overall prescriptions became more and more available. That started to kind of level off around 2011, and not too long after that, we see a very drastic increase in this blue line. That blue line is death from overdose from fentanyl. The toxicology screen can't tell if fentanyl is from the street or from an OR procedure, but the circumstances can. Often we know that the fentanyl that is killing people is illicitly obtained. Now, why are people getting illicit fentanyl? Very often is the case that people don't know they're getting illicit fentanyl. This is a picture, a screenshot I took from the DEA website showing two pills compared to each other, front and back on the left, front and back on the right. The one on the left is an actual oxycodone pill with the stamp of M30. The one on the right is a fake pill, a counterfeit. There is some oxycodone in it, but there is also fentanyl, which was detected when the DEA collected this. And that is one very important way that fentanyl is getting into the systems of our patients and causing severe harm. In fact, when the DEA tests their take, up to 4 out of 10 of these counterfeit pills will contain a lethal dose of fentanyl. And just to give you an idea of what lethal means, this is a picture from the Boston Globe in 2017. It's accurate today. On the right, carfentanil is only used in operating room settings. It's not a street drug. And behind that bottle is a picture of a dime to give you an idea for size. So 20 micrograms is a deadly dose for an adult male of carfentanil. Just a touch more, 3 milligrams, is the lethal dose of fentanyl. And then heroin, it's hard to see with the white background, but heroin, 30 milligrams. So this is all it takes for somebody to be killed by taking fentanyl. Now, I'm going to add one more caveat. I didn't come up with a good picture for this, but patients may not actually be seeking out illicit or street opioids. We are certainly aware of our patients who may be on opioid medication but seek out more from friends, family, loved ones. And that's one way that we can potentially see fentanyl get into the community. Another way, which is terrifying in my opinion, and which is something I want to bring up to this whole audience, is it's being put into other non-opioid counterfeit medications, including benzodiazepines, amphetamines. So we have the potential to see our patients, completely opioid-naive patients, take a medication thinking that they're getting something to relax or something to help them study for a test, thinking it's a medication because it looks like one, and it turns out to have a lethal dose of fentanyl in it because fentanyl is cheap, inexpensive to manufacture, and it adds a little euphoria to an illicit medication. And people are overdosing, having never otherwise experienced opioids. So I bring this up because this is of critical import, that we talk to all of our patients and remind them to only ever take their prescription from the pharmacy and nothing else, no matter what it looks like. The 2022 clinical practice guidelines for opioids came out for public comment earlier this year. It is now closed for public comment, and a final draft is expected at the end of this year. Some of the important things to pay attention to with this current document, which I think many of us will appreciate, is that the CDC has gone away from the 90 milligrams of morphine equivalent, MME, threshold, which was applied as a trigger to either wean a patient down to or move a patient on to more intense therapy, a pain specialist, etc. So that threshold number has been eliminated from the newest document. It is important, they emphasize, however, to always prescribe to the lowest effective dose, and I don't think that is ever going to change. The problem here that we have run into is that many of us have chronic pain patients that I like to think of as legacy opioid patients. They spent the last 10, 20 years being treated by us in the context of a community of overprescribing. For better or for worse, that's where they are, and we have to meet them there. We can't take them to where we want them right now. So having that flexibility really, I think, is a big improvement for this document. The document also relaxes the definition of the acute pain timeline, which was rather short, and does in fact concede that there is some evidence showing some benefit, very, very small functional improvement versus placebo for a very short period of time with opioids. Long before that, and for a long time before that, it was our mantra. In fact, what I learned in fellowship is that there is no evidence for opioids in chronic pain management. That is not entirely true. There is some functional improvement short term, but long term we continue to want for that evidence. And we know that there are better things to do, and most importantly, focus on multimodal treatment, exercise, physical therapy, non-opioid pharmacologic agents, injections where appropriate, surgery where appropriate, but focus on those and not the opioids. And the document reinforces that as well. All right, buprenorphine. Everyone ready for this? Buprenorphine has been around for a very long time. It was synthesized in 1977 to be a safe opioid. It was actually designed for pain relief and was indicated and cleared for pain relief in the beginning. It has very poor oral bioavailability, which makes it less than ideal to use, or made it difficult in the beginning to have big uptake since it was only available intravenously. But by the late 80s, 90s, buccal forms, sublingual and buccal forms had been developed and put buprenorphine out into the market more readily. It subsequently became packaged with naloxone and called Suboxone, and we'll talk about that in a second. I'm going to go through each of these points, coming after this first one. I'm going to go through each of these points with evidence to support each of these statements, but I just want to start with the statement, first, that buprenorphine is just as effective as morphine for pain relief. Even though it is a partial agonist, which we all know, it is just as effective as morphine. That partial agonist effect, in fact, is what gives it its safety. It has a built-in respiratory depression ceiling. We will look at that in a moment. The short-acting naloxone that is packaged with buprenorphine and the Suboxone tablet that we've all heard about is not meaningfully absorbed orally. Most of it goes out in the stool. If some is absorbed, its half-life is much shorter than buprenorphine, and that naloxone does not affect pain relief. You can easily co-dose buprenorphine with a pure mu opioid receptor agonist, so you can co-dose it with oxycodone, Percocet, morphine, and you will see additional pain relief benefits. And then finally, an issue that comes up a lot in my practice for patients who have been on high doses of opioids or have been on doses of opioids for a long time is they are often treating their pain, but also hyperalgesia or worsening pain that is caused by the opioids they are taking. So most of these all of the pure MORs are hyperalgesic, but buprenorphine, in fact, is not at all. So when we're treating buprenorphine, we're not causing more pain, and we're doing a good job of treating pain. All right, so this is the first piece of evidence I promised. Buprenorphine is just as good as morphine. In this chart, in this study here, which it's a little hard to see because I wanted to fit a lot onto the screen, but on the left is the pain score on a 0 to 100 scale, and on the x-axis is the time. So compared with an IV dose of morphine, sublingual buprenorphine is just as good, if not even a little better than morphine for relieving pain. Respiratory depression is one of the reasons, if not the most common reason, people die of opioids. As we increase the dose of an opioid, it directly acts on the respiratory center to decrease one's responsiveness to accumulating CO2. That decreased responsiveness eventually will end in apnea if we continue the increasing of dose. This study here demonstrates on the left fentanyl at increasing doses, and on the y-axis, the respiratory rate or ventilation. So as the dose increases along the x-axis, the ventilations go to 0. And this will happen. This may be shifted a little bit depending on somebody's previous exposure, but every human, every mammal will stop breathing on a pure MOR. On the right, we have buprenorphine, and same setup. On the left is ventilation rate, on the right is the dose of buprenorphine, and we can see that there is a flattening of that curve. Now, this is true, and it's very important. I will caveat that if somebody is also drinking heavily or taking a benzodiazepine or has issues with polypharmacy, this is not entirely correct. There could be further sedation of respiratory drive, but buprenorphine, compared to fentanyl, doesn't stop your breathing, which makes it a built-in, much safer medication. All right, naloxone, I mentioned this already, but I'm just going to come back to it. Naloxone is packaged with Suboxone. Why am I talking about Suboxone? The body doesn't know the difference between Belbuca, Butrans, Suboxone, Subutex, Zubsolv. Those are all different brand names of packaged buprenorphine. The brand names Butrans and Belbuca are lower doses, usually less than a milligram dose, and those are indicated and FDA cleared for pain. The higher doses are in amounts anywhere from 2 milligrams to 8 milligrams, and they can be dosed multiple times a day. And those are FDA cleared and indicated for opioid use disorder management. But the body doesn't know where you got your buprenorphine from. So I often, in my world, because I cannot access the sometimes branded, more expensive, FDA cleared Butrans or Belbuca, I will sometimes give somebody Suboxone, and we will get excellent pain relief with that. All they need is a 2 milligram film cut in half twice a day or 3 times a day, and they're doing great. But I often will hear, well, what about that naloxone? Pharmacists will call me back and ask me what to do about that. And I mentioned this already, and I'm going to reemphasize it. Naloxone is not absorbed orally or sublingually in any meaningful way. This graph here on the right demonstrates buprenorphine and its metabolite, its active metabolite, peaking and then leveling out. That really short line at the very bottom is naloxone. So very, very small amounts of naloxone make it into the bloodstream, and we will see this on routine urine screen monitoring, but it is a very small amount, likely untherapeutic for anything, and it also wears off very quickly. Naloxone has a short half-life. So why is naloxone and Suboxone, why is this packaged together? When buprenorphine was first put onto the market, brought out to the market for opioid use disorder management, we recognized that this is a high-dose medication and we're working with a high-risk population. We need abuse deterrence. So naloxone built into the film, if it was adulterated into a form that could be injected into a vein, would absorb into the system through the vein because you have 100% bioavailability there, and that would then block all of the dangerous effects of not so much buprenorphine, but maybe other things that are in the body like heroin. So, and it blocks buprenorphine to prevent any kind of high from a rapid injection. So the naloxone doesn't have a lot of meaning. It's there to protect people from injection, and that's it. And otherwise, it doesn't bother our pain relief. Let's see. This is an interesting study that shows when we're dosing buprenorphine, we are not occupying all the receptors, no matter, I mean, not no matter what, but even at doses as high as 32 milligrams, which is pretty much the highest dose you'll ever see somebody on. As we go up, on the left side of the screen, on the y-axis, that's mu-opioid receptor availability. So those are the opioids that are, the receptors that are available for binding any opioid. At a very small dose of buprenorphine, we have lots of opioid receptor availability. The table demonstrates or writes out what the chart shows. So let's go to 2 milligrams, which is a common very low dose OUD version, opioid use disorder, Suboxone version. When we dose 2 milligrams, we still have 60% of our opioid receptors free. 60% of them to be treated with IV morphine if we're in the hospital and we need to control pain after surgery. And likewise, as we go up, we still continue to have free receptors, even at a 16 or even 32 milligram dose. So pain can be additionally controlled. This is important because there's a lot of understanding and protocol development at this phase. I should say that we're trying to understand and develop protocols at this time for buprenorphine in perioperative care. That medicine is a fantastic medicine, as I keep saying, and it can safely be continued during the perioperative period. There's no reason to stop it. If it gets stopped, you're taking away a lot of potential pain relief that needs to be first addressed before the additional acute pain from surgery can be addressed. So the best thing to do is keep the buprenorphine going during the entire perioperative period. And one adjustment that can be made is we can take buprenorphine on post-op day 1 and 2 and 3, and we can take it from a once a day or twice a day dose and make it up to 4 times a day to spread out the analgesic effect. I won't get into that. That wasn't the point of my talk today, but that's a very important take-home. We can continue buprenorphine during the perioperative period and still achieve excellent pain control using secondary opioids or other things such as well-placed blocks, IV ketamine, and so forth. Buprenorphine can treat pain despite opioid use disorder. I really like this breakdown here on the left. at about 10 to 60% of receptor occupation, which is somewhere between 0.5 milligram and 4 milligrams a day, again, depending on the person, we get pain relief, which may be plenty for most people. But if somebody is dealing with issues such as cravings or early signs or clear signs of opioid use with disorder, we need to block those cravings, and we certainly want to block any kind of withdrawal, which can negatively reinforce the drug habit. So at 50% receptor occupation, we block cravings and withdrawal. And then if we really want to block euphoria, which can really drive a habit to form, we need to get about 75% with dose occupation, or receptor occupation. But there's definitely room and an overlap of pain control and opioid use disorder management. So we can use the same drug for both. I see that I'm going over my time, so I'm going to try speaking a little bit faster. This is an interesting slide. This is very interesting to me because I do see a lot of hyperalgesia in patients who are on chronic doses of opioids or briefly a high dose period of opioids. People will get more pain than their index pain, their wound, because the opioids cause the pain. Now this chart, Olene compares a couple of our medications, but fentanyl, right there in the middle, only has a small component of anti-hyperalgesia compared to buprenorphine, either IV or sublingual, which has a lot of anti-hyperalgesia effects. So we're not making the problem worse. The only thing that's better is ketamine, which is that one at the bottom. This is a great paper that I cite, and it gives me a lot of data for what I've told you already. But there are a lot of benefits to buprenorphine. The paper is called 12 Reasons for Considering Buprenorphine as a Frontline Analgesic in the Management of Pain. That was put out just, I want to say 2012, but it's very pertinent today. But buprenorphine, less constipation, it bypasses the gut. People don't have problems with that. Less cognitive impairment. There's no immunosuppression such as that which we see with morphine and fentanyl. It does not cause hypogonadism, which is a huge issue for folks who are on daily chronic opioid therapy for years. It does not prolong the QTC interval like methadone and also like oxycodone. It's safe in the elderly and renal failure. It end-stage hepatic disease, we do need to dose adjust, but that's the only time. And it's not reinforcing, so it's not going to trigger habit formation. All right, oh, and I added this just this morning because it came to me in my mind. Anyone with a DEA license can actually prescribe buprenorphine. If you're not comfortable with it, of course, you can send somebody for consultation, take your time to learn and understand the medication, but I will get phone calls from pharmacies saying, oh, you can't prescribe buprenorphine. I don't. I have a DEAX waiver. But before my waiver, I would get phone calls. And in fact, it is legal for anyone with a DEA license to prescribe buprenorphine at any dose for pain. And the key there is to indicate that it is for pain. The one that's the little bit harder to justify is that Suboxone product that bundles the naloxone. It's cheap and available, so I constantly prescribe it. The naloxone has no critical issue, but that confuses pharmacies sometimes, and we need to talk to our pharmacy colleagues to clarify that this is for pain, and that's why we're prescribing this. Okay, so I am moving a little slow, I apologize. So I'm going to move to ketamine for pain management. You may have seen that ketamine is really blossoming as an injectable agent in the field of chronic complex pain and mood disorders. We use ketamine in the OR and have used it for many, many years as an anesthetic. It's a very safe medication that maintains your blood pressure and your respiratory rate. So it has, again, built-in safety. But we have found that there's a dose somewhere in between the low-dose acute pain dose and anesthetic dose that will actually give somebody a prolonged pain relief effect. That prolonged pain relief effect often lasts anywhere from 3 to 8 weeks, so somebody can come in and get a dose of intravenous ketamine and have a component of pain relief that lasts 1 or 2 months. Well, since I'm 5 minutes over, I'm just going to really quickly go through this, but just NMDA receptors are critical in the development and chronification of neuropathic pain conditions. It's the NMDA receptor that ketamine acts upon. With overexpression of the NMDA receptor, patients can develop severe neuropathic pain that often is responsive to things like gabapentinoids. But again, this is the site of action for ketamine. So there is a huge need for this kind of medication, and this is the way it works. There is a secondary component to pain, though. When I think of pain, I always think of that there's two kinds of pain that anyone suffers. There's the wound, the site of injury, and then there's the suffering, and that's the affective motivational component of pain. So one may have arthritis that hurts in the knee, but if they have arthritis that hurts in the knee for 5 years, they're going to have a tremendous affective component because that arthritis has affected their function, it's affected their way of life. The circuit on A demonstrates the sensory discriminative component of pain. That's the ouch, it hurts in my knee because I have arthritis there. The circuit on B is the affective or the emotional component. That's how we grade our pain, how we respond to our pain. And then C is an overlay of both of them. We believe that ketamine is having an effect on B, and that is that circuit reset with a dose of ketamine is giving us that long-term pain relief. I just listed a number of disease syndromes that are associated with neuropathic type pain, which may or may not be of interest in the future for folks who may need ketamine. Emerging non-opioid pain therapies, and there is a lot. Our job as pain physicians is to offer the entire armamentarium of pain relief management strategies to patients, not opioids, not just opioids. But there's ongoing emphasis on multimodal care during the perioperative period. I understand there's a talk on that later on in this conference, so that is forthcoming. The CGRP receptor antagonists, not to use brand names, I can't think of how to, I can't pronounce their generic names, but these injectables and sublingual oral medications are a huge game changer in the world of migraine management, and we're really changing lives. This is emerging and has been emerging for the last 4 to 5 years. So it's a fantastic therapy. If any of your patients have migraines that didn't respond to anything, but they haven't explored these therapies yet, please do explore them. They're safe and they're effective. Also, Botox for migraine has been quite effective for many of these patients, as well as chronic pain syndromes related to spasm. We place Botox in muscle groups and can get prolonged relief in areas that cannot otherwise respond to muscle relaxation. RFA, radiofrequency ablation, which is what I do every day, is a technique that numbs up an area of interest and just affects the sensory component. We isolate that area from any motor component. It's very effective for arthritis type pain in the low back, and that's where we most commonly use it and have seen it used since 1975. The lumbar spine, thoracic spine, cervical and sacral spine are all eligible candidates, and we get tremendous relief when we anesthetize painful arthritic joints in patients. This field is growing because we see more applications as cadaveric studies are coming online and we're understanding peripheral nervous system better. The knee has a defined strategy, as does the hip, shoulder, and various peripheral nerves. Spinal cord stimulation, neuromodulation continues to evolve as software gets smarter. We can really personalize things to the patient. Dorsal root stimulation, peripheral nerve stimulation, still the same thing there. And then minimally invasive SI joint fusions, interspinous spacers. These are all the interventional world. Minimal invasive means a little bit of surgery, but this is not a lumbar fusion or cervical fusion. We're looking at the lumbar spine right now, but very promising and interesting stuff on the horizon. Long COVID, I'm not going to say much more except for there tends to be an apparent musculoskeletal neuropathic component, and treatment approaches may overlap with our approaches to fibromyalgia, so that is forthcoming. This is my last slide. Do I have any questions? Actually, I post my email address. Just don't pass it out to patients if you don't mind. Thank you.